Welcome, everyone. The Leukemia Lymphoma Society of Canada is proud to introduce today's presentation, New Guidelines to Chronic Lymphocytic Leukemia, the Latest Advantages and Emerging Treatments. In this session, Dr. Versha Banerji, a Canadian leader in CLL treatment and research, will provide the latest information on CLL diagnosis and treatment options. Before we begin, let me introduce myself. My name is Catherine Yerkew, and I'm a Community Services Lead for Manitoba and Saskatchewan with the Leukemia Lymphoma Society of Canada. I will be the moderator of this online event. We invite you to type your questions and comments in the Q&A box of your Zoom webinar panel throughout the presentation. An LLSC staff member will monitor the questions, and I will read some of your questions aloud at the end of the presentation. Due to the large number of participants and limited time, we may not be able to answer all of the questions. Also note that our speaker cannot answer specific questions about a person's health history or status. If we do not get to your question during the live presentation, a community services lead will contact you in the coming days. Today's presentation will be recorded. Therefore, you can rewatch it again on our website. Are you looking for specific programs or resources, but not sure where to find them? We're here to help. You can connect with the community services lead in your area to receive personalized assistance and get connected to resources in your area. Reach out to us by calling toll-free 1-833-222-4884. We invite you to visit our website. Our goal is to better serve the community and offer an improved experience. On our website, you will find tailored information and resources, including those specific to CLL. This includes recorded webcasts, podcasts, fact sheets, videos, and much more. Did you know the LLSC has an app where you can track your symptoms and side effects and much more? Download the free Health Manager app to help better manage your blood cancer diagnosis. It includes medication reminders, meal planners, medication and side effect trackers, plus shared caregiver access. This app is available for Apple and Android devices. We also offer programs that can help connect you with other members of the blood cancer community. We offer a peer support program where you can connect one-on-one with a peer volunteer, virtual support groups, and private CLL Facebook group. Connect with the community services lead in your area to learn more. It's now time to introduce today's speaker, Dr. Versha Banerji. Dr. Banerji is a clinician-scientist at the Paul Evertson Research Institute, CancerCare Manitoba, Associate Professor at the University of Manitoba, and a clinician-scientist at CancerCare Manitoba. She is the founding director of the CLL Clinical Care, Education, and Translational Research Unit in Manitoba, where she manages a multidisciplinary research team in clinical, fundamental, and translational research. Thank you for being with us here today. Over to you, Dr. Banerji.
Thank you very much for this kind invitation and allowing me to speak on treatments in the setting of the new guidelines, as well as the evolving treatment landscape. Next slide. These are my disclosures. Next slide. I think it's really important for all of us to kind of be on the same page. The focus of this talk is really going to be on the treatment, but I thought I would give a little bit of an introduction and allow for us to be congruent in our journey together so that we can all feel included. So CLL is a chronic condition that may require long-term treatment. The median age at diagnosis is 72 years of age, but I think it's really important to understand that 90% of the patients are 55 years and older. 89% of patients will have at least one medical condition at diagnosis. And I think it's really important to realize that this is a journey that lasts throughout a patient's life. CLL is rarely curable, and it may require treatment and long-term follow-up. including patients who don't require treatment with active observation. Next slide. So what are the primary goals of CLL treatment? I think we all really understand that the first goal is to try and control the patient's underlying condition with effective and long-term disease control. The next thing is really to do this in a way where we're managing people's symptoms and improving their quality of life. And that can only happen if we have treatments that are effective and tolerable. Next slide. But there's also secondary benefits to treatments. And I think these are some of the things we don't often think about at the outset when we're starting to talk about treatments. We know that CLL is a lifelong disease. We know as it accumulates in the blood or the lymph nodes, there's the ability to have what we call genomic instability of the cancer. But we also know it affects the immune system because we have cells that don't function normally and therefore don't communicate effectively with other immune cells. So with our treatments, we definitely improve outcomes. I think that we are all aware of, but we can also decrease genomic instability. And maybe we can reset the immune system. And this may lead to less infections and also reduce the risk of second cancers. Next slide, please. So bringing everyone to the same page, this is what the blood smear of a normal patient looks like. And the cells that are often abnormal are these lymphocytes. But the typical ratio is one of these lymphocytes to every 20 red blood cells. Next slide, please. But this is what that ratio looks like in the blood of a patient with chronic lymphocytic leukemia. We have an accumulation of these cells within the peripheral blood, but they can also live within the lymph nodes or the bone marrow, causing symptoms. They can also cause enlargement of the spleen. Next slide, please. So as we discussed, these cells travel between these compartments, and it's really important to note that CLL doesn't necessarily spread, but blood travels to different places, and these cells are growing within these niches. And the niches that are the most important for that growth are within the lymph node environment and the bone marrow space. This is where these cells get the nutrients to survive and grow. Next slide, please. So we're really in a situation where these normal cells that normally have a timed life cycle are no longer doing what they're supposed to be doing. The balance between cell survival and cell death and growth and no growth has been disrupted, where the CLL cell has increased survival and increased growth. Next slide, please. So what are the indications to treat? So we know that this is a chronic entity, and the management for the majority of patients is actually what we call active observation. And the active observation really comes from the setting that patients may have different amounts of disease at the time of their diagnosis and may not all require treatment at the same time. But the way that treatment is determined is based on the IWCLL criteria, where there's progressive disease, either bulky lymph nodes, a big spleen, or symptomatic disease that you're just not feeling well as a patient. And the other things that might lead one to require treatment are the recurrent infections. And of course, advanced Rye stage disease, where the hemoglobin and the platelets may be decreased as a result. So what types of treatments? Yes, thank you. What types of treatments are we talking about now? And so there's been a revolution of treatments over the course of the last, let's say 30 years, but more so in the last 15 years. And these have traditionally been treatments with chemotherapy in the 60s to the 2010s, but there's been new targeted treatments over the last 15 years. Next slide. So currently, the recommendation from a Canadian guideline perspective is that if someone is early stage and asymptomatic, there is a lack of overall survival benefit for an early intervention. And therefore, the active observation, or what has commonly been called watch and wait, is the number one recommended recommendation for this patient population. So this comes from a publication in leukemia research from my peers across the country, where we've all gotten together to review the current literature and provide recommendations to providers across the country and have information out for patients as well. Next slide. So in the past, our treatments were really determined based on the patient's qualities. And these included their age, whether they were less than 65 or greater than 65, if they were fit. And this was determined by what we call a comorbidity index rating scale. And this is a point system that gives patients points based on their other medical conditions and also the medications that they may take. So for example, if you wore glasses, you were given 2 points. And if you had high blood pressure and you were on a medication, and if you were on more than one medication, you could get 3 points. So you can see how the points add up. And if you had 6 points or more, you were considered unfit, and therefore your medical treatment would be determined based on that score. You also needed to have normal kidney function so that the drugs that we were using at the time could actually go through the body safely and prevent side effects in a patient. And so these are some of the key features that were what we used up until about the last 3 to 4 years in terms of how we would determine treatment. The choice of treatment has now evolved with the advent of molecular testing. So that's the next slide. How do we decide which treatment? So we're now using molecular testing to identify high-risk features in one CLL. So how do we do this? Next slide. So you'll hear me talk through this session about 3 different molecular abnormalities that are taken into consideration to determine a patient's risk profile. The first is the IGVH mutation status. So when we take patients at diagnosis, the majority of patients at diagnosis, 60% of them, will have what's called a mutated IGVH. And this represents the journey of this white blood cell through the lymph node. As it matures through the lymph node, it actually has a mutation that makes it move from an immature lymphocyte to a mature lymphocyte. And so it's considered a good risk feature. But if the cell remains in this unmutated form, it is considered high risk. And the reason for that is that it has a lot of immature capabilities that white blood cells have, which is they can grow and divide and proliferate, because the normal role of these cells is to fight infections, expand when needed, and to make antibodies. And so this is an important piece of the immune system that in this current situation isn't working the way it's supposed to. So at the time of treatment, the ratios actually flip. So 60% of patients who require treatment have an unmutated IGVH. Important thing is this does not change through the journey of the patient. So once a status is established, the test does not need to be repeated. And in Canada, these tests are happening prior to treatment because they inform which treatments we would give. A lot of the risk is really based on when we used to give patients chemotherapy as the main modality of treatment. As we have new treatments, the risk is almost even between these groups and they respond equally well. So I think that's a key thing to take home today. Next slide, please. The second test is done as it's called fluorescence in situ hybridization, but it's known as the FISH test. The FISH test allows us to see breaks in the chromosomes, and these breaks can lead to loss of certain genes. So 80% of patients will harbor at least one of the abnormalities that we test for, and there's 4 common abnormalities that we test for. Next slide, please. There's the deletion 13q. It's the most common. 50 to 60 patients will have this abnormality. And it was considered a good prognostic marker. However, with a new technology, we also know that it leads to increased expression of BCL2. BCL2 is a gene that's important in apoptosis, and it's considered an anti-apoptosis marker. And apoptosis is a fancy name for cell death. So basically, increased expression of this blocks cell death and increases survival of the cell. The second abnormality is an 11q deletion, and this is where a certain tumor suppressor gene is housed, known as ATM. I think It had more value in the era where we were giving patients chemotherapy, but in the era of novel agents, we see less differences in the outcomes of these patients. It still may play a role, but what that role is at this time as the landscape has changed is really important. The main high-risk feature that we are looking for is the deletion 17p. And the reason for this is that it leads to the loss of a tumor suppressor gene. The tumor suppressor gene is like a brake. And so if you lose the brake, the cell is in constant acceleration, which means it can grow and divide. And so this is a significant issue, both for when patients were given chemotherapy, but also we are now learning that it has an impact even in the era of novel treatments. Trisomy 12 is also something, so that's 3 copies of chromosome 12. There may be some biological relevance, but we don't actually use this clinically, but it is information we're still gathering to learn. Most important feature of this is that these are abnormalities that can reoccur or change with every treatment initiation. So they should be checked before every line of therapy. Some people may not choose to do so because really the only actionable one is the 17p deletion. And if you already have that, it's not really worth knowing if you have the other ones. Next slide, please. And so lastly is what we call sequencing for the p53 mutation. So this is a little different. So the other test is to look for chromosome losses. This is actually the chromosomes are intact and the genes are still present in a normal manner. However, the coding of that gene may make it inactive. And so if that mutation is present, it's not able to do its job in the way it's supposed to do. And so patients require the p53 gene to be in place to respond to chemotherapy. And this is why it was such a terrible prognostic marker in the era when this was the primary care we utilized. This is not really the standard of care at this time, except for a very small group of patients, which is also under debate, as you'll see later in this presentation. Next slide. Although not a clinically available test, I thought I would define measurable residual disease, as you might be hearing it a lot in talks, but it's really the ability to detect levels of disease at a certain threshold. It uses various different technologies, and this can be used to predict response to treatments along the patient journey. It is rarely done in Canada outside clinical trials, but it is something that we have to start thinking about as we start to establish guidelines, especially for the future. Next slide, please. Next slide. So chemotherapy has been the mainstay of CLL treatment up until the last 4 years. The typical agents that were used were fludarabine, bendamustine, and cyclophosphamide, and single agent chlorambucil or chlorambucil in combination with antibodies. And the main idea around this was really trying to prevent the replication of the cells so that they could grow and survive. Next slide, please. So these were often combined with what we call monoclonal antibodies. Antibodies directed against an antigen on the surface of the CLL cell, known as CD20, which basically attack the cell and literally cause it to lyse and break down. So it's a very targeted type of treatment. And this was often used in combination with the chemotherapies to enhance their efficacy. Next slide. So as you can see here, this is a publication from 2018, and it really demonstrated how we used things as single agents and added the antibodies to these single agents over time. And what you could see is as the treatment regimen became more complex, the ability to remain in a remission increased steadily over time. But that came in as a trade-in, and a trade-in that meant more side effects or toxicities, with some of the best regimens with the longest remissions having almost a 70 to 80% risk of a toxicity that could land you in the hospital requiring an intervention. And so those are serious things for patients to consider. But it was all we had, and we were able to provide patients remissions that were meaningful. But we're now entering a new era of targeted therapies. Next slide, please. So the the therapies that I'm going to describe are really what are being used in clinical practice, probably in the majority of patients, with a very few patients receiving chemotherapy today. Next slide, please. So the CLL cell uses multiple proteins that communicate together to allow the cells to survive and grow. And this signaling pathway that enables this communication is known as the B-cell receptor signaling pathway. So the drugs that have been designed to inhibit or block proteins that are downstream of this receptor in a way to shut down that signal. And the ones that we use, I would say, in 90% of our CLL patients right now are ibrutinib and acalabrutinib that target BTK, but emerging in the treatment landscape is zanubrutinib. These are known as covalent BTK inhibitors, and that's because they bind and stick to the BTK protein. And so when resistance emerges, it's because the drug can no longer bind because of a mutation that has arisen in the protein. There are other downstream mechanisms of mutations that can lead to the drug not working, but the most common is an abnormality. So in that binding. So this gives rise to, well, what do we do when this stops working? So now there's the development of what we call non-covalent BTK inhibitors. So that's pirtobrutinib and nemtabrutinib, and these are drugs that can work when people have failed or progressed on the previous treatments that I mentioned, and that's because they're not dependent on binding to that protein. Next slide, please. The other class of drugs that have really taken over are drugs that target apoptosis. And apoptosis is basically reactivating cell death. And this is by blocking BCL2, which I mentioned earlier. So venetoclax has been the mainstay of this type of treatment, but there are two new drugs fast coming into clinical practice. Well, I should say clinical trials. Sonrotoclax and listofoclax, which are drugs that are basically coming in to be used a little bit differently and in a different way to help. So we don't know if they're as good or different from venetoclax, but they're definitely given in a different manner. So we're looking at different ways that can help both patients and providers allow patients to receive treatments that are really effective. Next slide, please. So what I've posted here is what we've based a lot of our guideline on. And this is the provincial funding algorithm. And I know there are multiple people on this call, and I'm very grateful for everyone who is here listening to this talk. But really, in Canada, health is provincial, and there might be some slight differences around access to the different drugs. But what is here is what has been approved by the national body, which is working with the different companies in the provinces to allow for access to drugs. So the frontline treatment for young, fit patients that don't have high-risk features in 2023 currently is FCR, but that might be debatable after the information that I show you. For patients who are not fit for chemotherapy, especially FCR, the standard of care really had been chemotherapy-like treatments, but I think many people have transitioned. So if they have high-risk features, to receive either venetoclax or obinutuzumab in combination, or if they have very high-risk features such as a 17p deletion or a p53 mutation, either acalabrutinib, ibrutinib, or zanubrutinib. And these are treatments that are available in the first-line setting. Now, discussing the relapse refractory setting is a little bit more difficult, and I'm not going to make it a focus of my talk because it really depends what you got in the first line, which would really inform what you would get in the second line. And so a lot of these decisions, especially for the high-risk patients and for the patients in the relapse setting, depends on their medical conditions, how far they might live from the center, and access to coming and going depending on the monitoring required, but also some of the medical health conditions related to side effects that one might experience with these treatments. Next slide, please. so here you can see here our recommendation from the guideline really emphasizes a lot of the things that I've just discussed in that figure. So these are words to explain, and the category of evidence, category 1 being the highest evidence level for this type of treatment in these patients. Next slide, please. And if you're older and you have more medical conditions without P53 mutation, these are the options that are listed. So in this case, venetoclax, obinutuzumab, and BTK inhibition, whether it's acalabrutinib or ibrutinib, are considered category 1 recommendations. Next slide. So I think it's really important to note that there's been a significant amount of follow-up with chemotherapy, and we can't deny the evidence. So this is published in Blood in August of 2023. I apologize, the reference is missing, but it really does show after 19 years of follow-up with patients who had previously received chemotherapy with FCR, that there is a subgroup of patients who achieve what we call minimal residual disease negativity that may benefit to the point of cure. The problem is we don't know how to identify these people up front, and there are considerable side effects associated with FCR long-term. And the main concern is bone marrow failure or conversion to an acute myeloid leukemia, which is incurable and lethal. And therefore, these types of treatments really have to be selected for the right patient. And this rate is about 6% over the course of the treatments. And as we've seen, even in clinical trials that are being done in the last 5 years, this rate of MDS and AML still exists at a rate of 2%. So as much as we really want to find cure for our patients, we also want them to have long-term benefit. And these are some of the things that physicians are trying to improve upon when it comes to it. But for this young, low-risk patient population, this could be a potential treatment option. But many treatments are now evolving to compare FCR versus some more modern treatment. So next slide, please. So the CLL13 or the Gaia study is an example of one of these. And so I'm going to explain this figure, and I'm sorry I didn't explain the previous figure in detail, but what we have here is the progression-free survival. Each of the colored line represents one of the treatments. CIT stands for chemi-immunotherapy, and that was FCR or BR. RV is rituximab and venetoclax. GV is obinutuzumab and venetoclax, and GIV is a combination, a triplet of ibrutinib, venetoclax, and obinutuzumab. And I think what we want to show here is people want to know, are our new treatments as good as chemotherapy, and do they provide the same benefit that FCR has demonstrated? And so I think one of the key messages here is in this patient population, the 4-year progression-free survival rates with chemi-immunotherapy were only 62%. And rituximab and venetoclax, which is often used in the relapse setting, was in this case used in the frontline setting because no one really knew if rituximab and obinutuzumab are equivalent in combination with venetoclax. We know that in combination with chlorambucil, obinutuzumab was better. So we wanted to answer this question as well. And it's clear that obinutuzumab and venetoclax was better than the last 2 treatments that we discussed. The question that we don't know the answer to right now is, are 3 drugs better than 2 drugs? And because of the amount of data that's available, I'll just speak to this, that these 2 arms are not different. And when we look at the depth of response by measurable residual disease, the reality of the situation is both of these treatments are effective. And one of the things that comes out when you give 3 drugs instead of 2 is that there might be more side effects for patients with the more intense combination with 3 drugs in the treatment. So this is something we have to learn more about and understand better. Is it safer and effective, or is it effective but not safer? And so these are things that we'll explore. So right now, this is a question: can we give obinutuzumab and venetoclax to our low-risk mutated patients with the same benefit that we derived from FCR? And this is something we need longer-term follow-up for, and we need to find out who are the patients that benefit. Next slide, please. So this was our young fit population. Now, if we think of our older fit population, the treatment that established kind of the backbone of therapy with venetoclax and obinutuzumab was compared to the standard of care of the time, which was chlorambucil obinutuzumab. And there's been updated publications in this really demonstrating a gap between the two. And so this was a treatment that was provided in a time-limited fixed manner, and the venetoclax and obinutuzumab really provided an important advantage from a progression-free survival perspective, really winning over the standard chemotherapy of the time. Next slide, please. So venetoclax and obinutuzumab has really entered the scene, but the mainstay of therapy prior to that was really the BTK inhibitors. So the BTK inhibitors, and in this case, acalabrutinib and previously ibrutinib, were really being looked at in comparison to chemotherapy and to see if these were better. One of the things we have to understand is BTK inhibitors, unlike venetoclax in combination with an antibody or the chemotherapy, are given in what we call a continuous manner. And a continuous manner means these are patients that are taking medications every day, just like a blood pressure pill or diabetes medications. And so they're not stopping their treatment. So we have to think about that when we think of the comparison between the two arms. The chemotherapy here was only for 6 months. And so it is really important to understand that patients got 6 months of therapy. And yes, they progressed, but they weren't on continuous treatment. So what we could see here is in the early follow-up period, as well as in the later follow-up period, the acalabrutinib containing arms were better, and the chlorambucil obinutuzumab was outperformed, but keeping in mind the time that these patients are on therapy. So an update was presented at ASH this year. So next slide. And this actually shows that if we look at the progression-free survival and the overall survival, that there's further separation between the acala-containing curves when it comes to progression-free survival. And maybe there might be a separation or a trend towards an overall survival by adding obinutuzumab. And so I think this is an important piece of information, because in Canada, this regimen is not funded with obinutuzumab in any province outside of Quebec. But if you have a patient that may not be responding, it might be something to consider and a request on a case-by-case basis. Next slide, please. So now I'm going to move into a realm of treatment combinations that currently are not funded or in the Canadian healthcare system, but have a Health Canada approval. So this is the combination of an oral treatment with ibrutinib and venetoclax. So this was a phase 2 study, and a phase 2 study is a study where there's no arm to compare with standard of care. So this is an important feature to understand. And this particular study was designed for what we would call younger patients, less than 70 years of age. And so this is patients that are often given 3 months of ibrutinib as a lead-in, and then they start the venetoclax. And the reason for this is venetoclax is a challenging drug, as some of the patients on this call may be aware, to start for patients, because it's given in what's called a ramp-up fashion. And the ramp-up requires blood work up to 3 times a week to determine if it's safe to move forward, not just with the current dose, but with the next dose. And the larger your tumor bulk is, the higher risk you are for changes in your blood work. And so the idea was, if we gave this oral treatment, just like we did with the intravenous for obinutuzumab prior to the venetoclax, can we debulk patients and prevent this risk of what we call tumor lysis? And so it was given over the course of 12 months in combinations. And what we can see here is the impact on patients without high-risk features and with high-risk features. And I think it's really important to realize that the progression-free survival with those with a 17p deletion was about 81% at 36 months and 91% without. So there is a difference between the high-risk population. And I think one of the questions is continuous therapy better, or is time-limited therapy better? But it's important to note that there's some advantages to time-limited treatment. So people develop mutations and resistance because of chronic exposure to therapies. So if you give someone time-limited treatment, then you might actually reduce the mutation burden and allow for what we call retreatment, because you're not actually resistant to these medications. You have done what we had done with chemotherapy before, which is relapse. And in the past, when people would relapse after chemotherapy, and as long as they had a good response, we would give patients the same chemotherapy. So I think it's really important from a concept perspective. I don't know how this is going to play out in the Canadian field, because there have been some concerns about the safety of ibrutinib, mainly related to heart and sudden death. So heart arrhythmias and sudden death. And unfortunately, some of these trials were also happening in the era of COVID-19. And so a lot of the information is also muddied because of that. And so we're still trying to understand the long-term benefits when it comes to the side effect profile. We can clearly see these drugs are effective in combination. So the next step was to look at that in a phase 3 study. But the next slide, please. So the phase 3 study was actually in an unfit population or greater than 65 with multiple medical conditions. And so this looked at chlorambucil and obinutuzumab as a standard of care in this group after 12 months of therapy, and ibrutinib and venetoclax. And so I think it's really important to see here that the arms do separate. And I think it's important to note that ibrutinib and venetoclax do better. I think one of the things that we wanted to demonstrate is that the progression-free survival is improved with this oral combination. And I think it's really important to see also the advantage that the combination has in achieving higher rates of undetectable measurable residual disease, which I think is an important factor. And you can actually see that with time, the ibrutinib venetoclax patients stay in that undetectable phase longer than the chlorambucil obinutuzumab patients. And so this leads to deeper responses in the ibrutinib venetoclax patients compared to the chlorambucil obinutuzumab patients. So this may play into the fact that these patients may not develop mutations as easily as the people that were chronically on BTK inhibitors in the past. Next slide, please. So the study, I think, that gained the most interest at the American Society of Hematology meeting was published on the same day that it was presented in the New England Journal of Medicine. And this was the UK FLAIR study. And the UK FLAIR study included patients who were being treated with FCR, so young, fit patients versus ibrutinib and venetoclax. The average age of these patients was similar at 62. There was a 2-to-1 male to female ratio. You can see the demographics of the different racial groups that were enrolled in the patients, accounting for the population within the study sites. And the majority of patients had advanced disease. As I mentioned, majority of patients were unmutated, and there was one patient with a p53 deletion. So not meant for patients who had the very high-risk disease, because the standard of care was FCR. Next slide, please. And we know patients who have a p53 mutation or 17p deletion do poorly. And so the progression-free survival is presented here. And so you can see that both arms separate when we look at all comers. So when we look at patients with unmutated IGVH, the patients respond significantly better. And we know that chemotherapy is not a great treatment for patients with unmutated disease. So the IV outperformed the FCR group significantly. But I think it's really important to show that patients who are mutated with an IGVH, there's really no difference in the outcome for those patients, clearly identifying FCR as still an option for these patients. Next slide, please. So a lot of things we have to think about when it comes to initiating treatment for patients is not only the efficacy of the regimens, and I've presented graph after graph demonstrating our newer treatments are better than the standard, but I think we also have to pick the patients that might benefit from these treatments in a very important way. So some of the side effects related to BTK inhibitors is because they work by binding proteins. Proteins have some similarities across their structures. And so even though these are specific targeted agents, there are off-target side effects. And so BTK inhibitors are known for their ability to cause abnormalities within the heart rhythms of patients. The most common is atrial fibrillation, which many physicians know how to manage and is something that happens naturally with age in patients as well. But it can be a significant impact for patients because now they have another medical condition. They need to use additional medications to control their symptoms. And when we had nothing else to offer our patients, we used to do this because we were salvaging patients after they had relapses in a chemotherapy-driven era. But now we're really looking at patients with so many different options. So we have to think of the safety of these regimens when picking the treatment for them. But other side effects include high blood pressure, heart failure, bruising and bleeding. And in the older generation, skin infections and nail changes were very common. But with the new treatments, these have become lower when it comes to the skin-related side effects and the nail-related side effects. But the bleeding and bruising is still something that we still have to monitor for, along with the heart-related issues. I will say infections happen with any treatment we give a CLL patient, and this is because we're disrupting the immune system and the communication between the different cells, including the normal cells that are there to fight off infections. Some of them are drug-related side effects because we cause low blood counts, including the normal healthy blood counts, but this is something that would happen with any treatment, even in the era of chemotherapy treatments. Next slide, please. When it comes to BCL2 inhibitors, the main issue is the breakdown of the cancer cells that lead to mineral imbalances in the blood that could affect the heart and the kidney. You can also get low blood counts and infections, as I mentioned. So when you put these two treatments together, these impacts can be amplified. And so some of the things we have to think about is the tolerability of the treatments. What I didn't put in here, and I don't have a slide about it, is the obinutuzumab. It can create an infusion-related reaction, which can be upsetting to patients. It can be upsetting to the nurses that are providing this. So we need to do this in a controlled setting, and we have protocols that we've developed to help other centers, including our own, manage a lot of these novel combinations. And so we have to think about the patient at the center of this, and how can we manage the side effects by giving them the best experience possible, including the best efficacious treatments. Next slide, please. So I'd like to move on to relapse refractory. I'm not going to introduce the drugs, but basically the treatments that are approved for relapse refractory include BTK inhibitors like acalabrutinib and zanubrutinib, and I'll show a slide on zanubrutinib. And these are favored over ibrutinib, and that's because of the side effect profiles associated with them. Venetoclax and rituximab is an effective fixed duration treatment. It was studied in the context of after chemotherapy, but we know that patients that have progressed after a BTK inhibitor can also respond to this treatment, plus or minus the antibody. In some provinces, you can give continuous venetoclax, but this may not be the same in all of the provinces. So I think here we have a situation where it really depends on what you got in the first line to really discuss the second line. So I'd like to move on to the next slide and just discuss two other presentations from ASH. One is the Murano study, which is looking at relapsed refractory patients who received venetoclax or rituximab in the second line versus bendamustine and rituximab, and also got a second treatment after their relapse. And I think it was really important to note that before someone got a second treatment, patients who received venetoclax and rituximab in the second line setting almost had a double progression-free survival compared to those with bendamustine and rituximab. And I think that's really valuable information to show that the duration of the remission is really much longer with these novel treatments. So next slide, please. And the other trial I wanted to talk about, because we're all concerned about the safety of novel BTK inhibitors. And so the Alpine study discussed their findings when comparing zanubrutinib to ibrutinib, and they demonstrated a continued improved response with progression-free survival with zanubrutinib. And so this is something where acalabrutinib with ibrutinib has shown equivalence, but we're now starting to see zanubrutinib after long-term follow-up showing an advantage. And so a lot of the decisions are made around efficacy, but we also have to think about tolerability. So next slide, please. Here you can see the side effects, and the side effects of zanubrutinib and ibrutinib, for the most part, the serious cardiac adverse events were lower. The rates of atrial fibrillation were significantly lower, 16% to 6%. One of the things that was not mentioned in here was the rates of hypertension. And this is one of the day-to-day side effects that physicians and patients have to manage. And these rates were not different. And they're somewhere between the 15 to 20% range in these patients. So I think this is an important piece. So although zanubrutinib and acalabrutinib are great BTK inhibitors in the relapse setting, you're going to have to pick the patient you want to put on it. One based on efficacy, the other one based on tolerability. And you're going to have to put the patient front and center to have these open conversations as to the considerations in this decision-making process. Finally, I'd like to end with the last data slide, and I know this is a lot of information, but this is about covalent BTK inhibitors. So covalent BTK inhibitors are acalabrutinib, zanubrutinib, and ibrutinib. And pirtobrutinib is a non-covalent BTK inhibitor. So these are patients who were enrolled on a phase 1/2 study after they had progressed off of a BTK inhibitor, and then were subsequently either exposed to venetoclax or a BCL2 inhibitor or not, and what the progression-free survival was after. And so I think it's important to note that pirtobrutinib is a great drug. And if you've been BCL2 exposed, the progression-free survival is about 15.9 months. That's a little bit less than compared to those that have never been exposed. So this is important for sequencing. So I'll let you go to the next slide. This is the slide before. Next slide, please. Which demonstrates that the progression-free survival, if you're naive to a BCL2 inhibitor, is about 23 months. So this is going to play a really big impact as we decide which treatments are going to come into the landscape. So I don't think it's going to get easier. I think it's going to get more complex, but I think that's really good for patients because there's going to be options. Next slide, please. So in Canada, I think the debate exists who benefits from time-limited treatment versus continuous therapy. Right now, high-risk patients are getting continuous therapy, but we have seen some effective time-limited treatments with venetoclax and obinutuzumab. I think low-risk patients are no longer getting chemotherapy, and you can strike off FCR, BR, and chlorambucil obinutuzumab. And if venetoclax obinutuzumab is doable and accessible, then it's really the standard of care. But we do have patients that can't do this, and therefore those continuous therapies like ibrutinib and acalabrutinib will be the ones coming in to play for those patients. Next slide, please. I think all patients can benefit from clinical trials, and I think it's really an option if any patient has the opportunity, so that we can determine how do we improve income, outcome? How do we reduce toxicity? And how can we stop treatments, especially when we are worried about their long-term side effects? Next slide, please. So I think the future is bright. I only talked about treatments that are close to coming to clinical practice, but the reality is there's so much happening in the CLL space with the immunotherapies coming down the pipeline, looking at different ways to stop treatment. Can we incorporate measurable residual disease? Can we stop treatment, have fixed durations? Can we decrease mutations, therefore more options? Can we improve the immune system? So many things are happening in the CLL space that are going to benefit our patients in the future. Last slide. So I think the algorithm is going to evolve. Is venetoclax and obinutuzumab going to move in to the young fit setting? Are we going to have BTK and BCL2 combinations in all settings? This is where the landscape changes. We've now added zanubrutinib to the guidelines, and they are actually in the process of dealing with provinces for funding, but there's access to patients to the drug through compassionate access at this time. So we have more things than we've ever had, more options than we ever had, and it's really an amazing place to be. So I thank you for your time today. And I'll switch it over to Catherine.
Thank you, Dr. Banerji, for sharing your expertise and insight with all of us. It's now time for our question and answer period. If you haven't done so already, please be sure to use the Q&A box in your Zoom webinar panel to type your questions. As we mentioned earlier, due to the large number of participants and limited time today, we may not get to all your questions. So if we don't get to them during this presentation, a community services lead will connect with you in the coming days. We're just going to go to the question panel. All right, so Dr. Banerji, I'm just going to present you with some of the questions that came out over the presentation. So the first question is, does immunoglobulin replacement therapy help in avoiding treatment by improving the ability to fight infection by increasing the IgG and gamma globulin levels?
So thank you for that question. So we didn't touch upon this, but patients, some of the patients, as they progress with their disease over time, their ability to make those antibodies, immunoglobulin IgG, can decrease over time, and they definitely can become more susceptible. I think it's hard to equate replacing immunoglobulin with being treated for your CLL. I think those are two separate entities. Patients can have immunoglobulin replacement because they meet certain criteria, but that doesn't necessarily control their disease. And so there may be other factors that lead to infections, specifically the communication between the different cells that is also not happening. So it might alleviate some of the infections, but it may not eradicate them entirely. So I think sometimes most patients who are at a point where they need treatment, sometimes these things are given hand in hand, or even after treatment is completed, to help prevent ongoing infections because of therapy itself.
Thank you. So how do you define recurrent infections?
So these are mainly defined based on meeting criteria for immunoglobulin replacement. And so it's usually 2 infections or more requiring prescribed antibiotics within a 6-month period of time, and have a low immunoglobulin of less than 4 to require replacement. But we often look at recurrent infections as those more than 2 infections with a 6-month period requiring prescriptions, or a severe hospitalization that required IV antibiotics. And so those are kind of our criteria for severe or recurrent infections. We often tell patients, however, that are not requiring antibiotics, that if you're having recurrent viral infections and they're not resolving within the typical 7 to 10 days, and your symptom period is like 7 to 21 days, we know that you're not recovering as fast, and that keeps happening. That would also be something to think about as a recurrent infection.
Great, thank you. So can you tell us what are the symptoms and signs of an enlarged spleen?
So there's two key features for the spleen. One is it lives in the rib cage on your left side. And so what happens is as it expands kind of diagonally into the abdomen. And as a result, it can compress the stomach. So people start feeling what we call early satiety. They feel full fast. And so they are often not able to eat the meals that they would normally eat and kind of feel full. And so that's one of the issues. Sometimes if the spleen is extremely large, people can't actually sit at 90 degrees and they need to recline back to make space in the room of their abdomen. Sometimes people experience back pain. So these are some of the typical symptoms. Now, remember, a spleen has to be very enlarged to do this. If one can feel a spleen on clinical examination, I was taught by my predecessors that the spleen is almost 4 times its normal size. So it has to be very big often to cause those symptoms. So it can happen gradually over time. And sometimes we adjust our behaviors because we're like, oh, I don't feel so full. But sometimes knowing this, cues you in, and it's one of the teaching points I give to the patients to report back on in our appointments.
Great, thank you. Can DEL17P status over disease progression, and do you retest at progression?
Yeah, so if you have it, then it's not worth testing for. Because we're going to find it again, likely. So if your disease relapsed and you were 17P deleted beforehand, the issue is when you didn't have it at your first treatment, we would want to know if you have it now. So yes, we would retest if you didn't have it.
Perfect. All right. Is MRD a meaningful clinical outcome like PFS, and can you test for it in clinical practice?
So I think that's $1 million question that a lot of people are struggling with right now. I think people are looking at it in clinical trials, and the UK FLAIR study that I talked about actually had an MRD-driven endpoint on discontinuation or retreatment with ibrutinib afterwards. I think the reality of the situation is I think it might become meaningful to stop treatment if someone's in a deep remission. I think it's harder to know if we should be using it to reinitiate therapy outside of potentially some high-risk patients because the remission period is so long. And, the clinical signs of disease relapse are probably equally good. If we treat people just because they have a number versus no symptoms or no evidence of disease that is creating symptoms for the patients, are we doing them justice? And we don't know the answer to those questions.
Okay, perfect. So when CLL becomes non-Hodgkin's lymphoma, is that a mutation? And why does this happen?
So unfortunately, this is a challenge with naming things. So the nomenclature. So technically, CLL falls under the category of non-Hodgkin's lymphoma as a disease entity itself. But its sister disease is known, or brother disease, however you want to term it, is called small lymphocytic lymphoma. And so what happens is that you have a clone of cells that is progressing and growing, and the compartment in which they are growing is what defines the disease. For leukemia, you need a minimal threshold of these clonal cells within the blood to meet the diagnostic criteria. So if the disease is mainly in the lymph nodes and you haven't met that threshold within the blood, that is when it's considered small lymphocytic lymphoma. And often people define that as a non-Hodgkin's lymphoma, where they're hesitant to use that term for CLL, but we're really under the same umbrella.
Thank you. Can you discuss what is an infusion-related reaction?
So an infusion-related reaction that is often used to define what people experience when they receive a monoclonal antibody is you have to understand the drug is very targeted. And so what happens is when it hits these cells break apart and release their contents into the bloodstream. And when they release the contents in the bloodstream, these are cells that are known to create an immune reaction because they fight off infections. Like when you get the flu, you feel unwell. It's kind of those same symptoms, but amplified because we're targeting all these cells at the same time. So when obinutuzumab is given, it's given at 100 milligrams on that test day and then 900 milligrams on the subsequent day. And the rates of reaction on day 1 are many. The rates of reaction on day 2 are almost none. And that's because your body has seen it and understands it and is not responding in the same way. And there's not a lot of cells in the bloodstream to actually attack. And so the reaction rates are less as a result. People can experience this. It's not a comfortable feeling, but it's very well supported and very well managed by the treatment room and the protocols in place. So that's typically what is termed an infusion-related reaction. It's not really an allergy to the drug, and I think that's different than with rituximab, where there are meaningful allergies and people need desensitization. With obinutuzumab, I think it's entirely based on the breakdown of the cancer cells.
Great. Thank you so much, Dr. Banerji. That is all the time we have for questions today. I know that there's many more questions, but I just wanted to thank, again, Dr. Banerji for joining us today, and your expertise is just very valuable for us. We want to kind of move over to sort of the ending of our webcast today. And I wanted to just mention we have 2 upcoming events taking place in the new year. January the 16th, we have non-Hodgkin's lymphoma, progress and understanding and treatment. January 17th, Hodgkin's lymphoma, progress and understanding and treatment. Registration is now open for both of these webcasts, so save your spot today. We would also like to thank AbbVie for their support in making these events possible. Please remember that we are here to help you. You can reach us by email by visiting our website, bloodcancers.ca, or by calling us toll-free. Please note that a short survey will be sent to all participants after this presentation. Please take a moment to respond as it helps us plan future events. Thank you for being with us today and take good care of yourself.
Thank you, everyone.